Hey guys, welcome to Prasu'S Medledge. I hope you all are doing good and have watched my previous videos. If not, what are you waiting for? Go for those after the end of this video. Now without wasting any time further, let's get into today's topic, that is organophosphate poisoning. A very important topic that is from university point of view and also from clinical practice. It is an important question in pharmacology as well as in medicine. So after listening this video, you can write this thing for your pharmac paper and also for your medicine paper. So organophosphate poisoning is one of the most common poisoning all over the world. The pathophysiology behind that. Organophosphate compounds, they usually bind to acetylcholine esterase enzyme and causes the accumulation of acetylcholine at the muscarinic and nicotinic receptors. So what organophosphate compounds do is that they bind to the acetylcholine esterase and they inhibit the action of acetylcholine esterase. As a result, there is accumulation of acetylcholine at the muscarinic and the nicotinic receptors. So these two receptors get stimulated, which is called as cholinergic stimulation. Now coming to the clinical features of organophosphate compound poisoning. So it is divided into three. That is, first is muscarinic effects, next is nicotinic effects, then central effects. So muscarinic effects can be remembered by the mnemonic sludge, in which S stands for salivation, that is increased salivation, then L stands for lacrimation because of activity of the lacrimal glands, there will be more tearing, then U stands for urination, that is involuntary urination, D stands for diarrhea, and G stands for GI cramping, that is abdominal cramps, basically abdominal pain, and E stands for emesis, that is vomiting. Now coming to the nicotinic effects, in this we are having twitchings, fasciculations, muscle weakness and paralysis. Twitchings and fasciculations are also occurring in the muscle only, and muscle weakness and muscle paralysis. Now coming to the central effects. Central effects include headache, confusion, convulsions, coma and finally death. Now coming to the investigations and diagnosis in case of organophosphate compound poisoning. First, there will be history of exposure. That is, we will get the history of exposure of the patient with this organophosphate compound poisoning. Also, we can see the characteristic signs and symptoms of organophosphate poisoning in the patients. And what is the investigation which we are going to do? That is, we are going to look for the serum pseudocholine esterase levels in the patient. Now coming to the treatment. So first step should be remove the contaminated clothes, that is which is containing the organophosphate compound, and also wash the skin of the patient with soap and water. Next is gastric lavage should be done till the returning fluid is clear. So basically we are doing stomach wash so that all the poison is coming out. Basically we are trying to remove all the organophosphate compounds. Next is airway should be maintained in this patients, because as I already mentioned, there can be muscle paralysis, so airway should be maintained. Next is artificial respiration should be given if it is required in the patient. Diazepam should be used cautiously with slow IV injection to control the convulsions, which is a central effect, as you can see in organophosphate compound poisoning. Next is we have to catheterize the bladder of the patient before starting atropine. Now coming to the specific measures, which includes administering two drugs. So first is atropine. It is the first drug to be given in organophosphate poisoning. We inject atropine 2 mg IV stat that is immediately, and it should be repeated every 5 to 10 minutes, doubling the dose if required till the patient is fully atropinized. Fully atropinized means the patient will be having fully dilated and non-reactive pupils, and this atropine should be continued for 7 to 10 days. Now mechanism of action of atropine. So basically organophosphate poisoning, that is organophosphate compound poisoning, OP stands for organophosphate. It causes increase in the acetylcholine levels. So this acts as an agonist on the muscarinic receptors, and atropine is the competitive antagonist of acetylcholine, as you can see here. So atropine is going to bind to muscarinic receptor. As a result, there will be no action of acetylcholine. So atropine competitively blocks the muscarinic effects of organophosphate compounds. Okay. Next drug which we are giving is pralidoxime, that is 2 gram IV over 4 minutes. It works by reactivating the acetylcholine esterase enzyme, which has not gone aging. Now what about this? So basically the acetylcholine esterase enzyme has got two sites, that is anionic site and esteratic site. Okay. So organophosphate compounds inactivate cholinesterase by phosphorylating this esteratic site of the enzyme. So oximes bind with high affinity, oximes that is pyridoxine with high affinity to the anionic site, okay, and then dephosphorylate the enzyme and then reactivate the acetylcholinesterase enzyme. So early administration of oximes, that is pralidoxime, is necessary before the phosphorylated enzymes gets aged. So before the phosphorylated enzyme is getting aged, we had to administer the pralidoxime, and by aging I mean there is loss of the alkyl group of the phosphorylated enzyme. Now coming to the complications of OP poisoning, I hope the treatment is clear. So basically we had to do specific measures and the symptomatic management, which includes we have to remove the contaminated clothes, wash the skin with soap and water, then gastric lavage is to be done, airway should be maintained, artificial respiration is provided if required, diazepam should be used to control convulsions, and catheterize the patient just before giving the atropine. And atropine is the first drug to be given, it is the drug of choice. You have to give 2 mg IV stat and it should be repeated every 5 to 10 minutes, doubling the dose, and if required till the patient is completely atropinized, and should be continued for 7 to 10 days. And next is pralidoxime, that is 2 gram IV over 4 minutes. Now coming to the complications of organophosphate compound poisoning. So first is intermediate syndrome, which is characterized by weakness spreading from ocular muscles to the head and neck muscles, and then to the proximal limb muscles, that is upper limb muscles, and finally muscles of respiration. Since muscles of respiration are affected, so it leads to respiratory failure. The management is simple, that is supportive care, that is basically we will do the airway management in these patients. Next complication is organophosphate induced delayed polyneuropathy, that is affecting the nerves. Many nerves are being affected, that is polyneuropathy. So the management for this will be physiotherapy. Okay, so this is in short about organophosphate poisoning. Now let's once again go through it. So it is one of the most common poisoning. Then I have told you about the pathophysiology. Then there are clinical features in that we have to by heart, that is muscarinic effects, nicotinic effects, and central effects. Muscarinic effects can be remembered by the mnemonic, that is sludge. Then we have investigations and diagnosis. In investigations and diagnosis, first we will be getting an history of exposure, then there will be signs and symptoms of organophosphate poisoning. In investigation we look for serum pseudocholinesterase levels, and treatment I have already mentioned you. The specific measures are there, and the symptomatic measures like maintaining the airway and removing the poisons from the stomach by gastric lavage. That's it. And coming to the complications, one is intermediate syndrome and the other one is OP induced delayed polyneuropathy. So that's it. I will see you in the next video, guys. So if you like my content, please do like, share and subscribe, and also comment and turn on the post notifications. And if you guys have any doubt, you can always comment that in the comment section. Till then,